47 seconds. That is how long the gunfight at the OK Corral actually lasted. 30 shots fired in a space smaller than most living rooms. And when the smoke cleared, 3 men were on the ground. Hollywood will tell you that is where the story ends. The smoke, the silence, the hero walking away. What Hollywood will not show you is what happened in the hour after, in the back room of the nearest building, on a table that was not designed to be a surgical surface, where a man who had been shot was about to discover that the bullet was not the worst part of what had just happened to him. Welcome to the raw frontier. Today, we are going to the operating table. You are going to learn why a gunshot wound on the frontier was not an injury, with a beginning and an end, but a biological event that set in motion a sequence of consequences that the medicine of the period was almost entirely unequipped to interrupt. The bullet was the opening act. What followed it was a main event, and the main event lasted days, and it was conducted in agony, and it killed more men than the bullet itself ever did. The image is precise and it is wrong, and it has been repeated so many times across so many films that it has achieved the status of visual fact. The hero takes a round in the shoulder. He grimaces, he keeps fighting, or he retreats to a room where the doctor works briefly with forceps and produces, with a satisfying metallic ring against a tin tray, a single clean intact bullet. The wound is dressed. The hero is sore for a scene or two. Then he is fine. The bullet came out whole, and the body closed behind it, and the story continued. This is not what a bullet does to a human body. It is not what the bullets of the frontier era did. And the difference between the Hollywood version and the biological reality is the difference between a needle passing through fabric and a rock being thrown through a window. The firearms that defined the American frontier, the Colt single-action army in .45 caliber, the Winchester rifle in .44-40, the various revolvers and long guns that populated the period fired projectiles made of lead. Soft, dense, relatively slow-moving lead, in comparison to the jacketed high-velocity ammunition that military and civilian firearms would later use. This metallurgical fact determined everything about what happened when one of these projectiles encountered a human body. A modern jacketed bullet is designed to maintain its shape through the target. The copper jacket preserves the lead core's integrity, allowing the projectile to punch through tissue and exit with a wound channel that, while serious, has a defined and consistent geometry. A frontier-era lead projectile had no such jacket. It was soft metal moving at sufficient velocity to penetrate the body, and then, the moment it encountered significant resistance, to deform. Flesh resisted. It deformed. Bone resisted catastrophically. It did not merely deform at that point. It fragmented. The entry wound of a large caliber lead ball or conical bullet was not the neat circle of Hollywood's imagination. It was compressed impact site surrounded by tissue that had absorbed the shock of the bullet's arrival and responded accordingly. But the entry wound was the least of what the ballistic event produced inside the body. The bullets passed through tissue carved a cavity that exceeded the projectile's own diameter due to the temporary displacement of tissue away from the path of travel, a phenomenon that created damage in a radius around the wound channel that the bullet itself never physically contacted. Organs adjacent to the path of travel sustained injury from this effect without the bullet touching them. Tissue that appeared intact from the outside was disrupted at the cellular level along the entire length of the wound channel. When the bullet reached bone, the event changed category. The femur, the pelvis, the bones of the shoulder joint, the ribs, all of them received the bullet's remaining kinetic energy in a collision that the bone could not absorb without structural failure. The fracture was not the clean transverse break of a bone snapping under bending stress. It was the explosive fragmentation of a structure that has received a high-energy impact at a point, producing shards and splinters that then became secondary projectiles moving through the surrounding tissue with their own trajectories and their own capacity for damage. A bullet that struck the thigh bone did not break it. It detonated it. And the resulting fragments traveled to the muscle in directions that had no relationship to the original bullet's path. What came out of a body that had been hit by a frontier-era lead projectile, if anything came out at all, did not resemble what went in. The bullet had mushroomed, flattened, and fragmented against the resistance it encountered. Some portion of the original projectile might be recoverable as a recognizable mass. The rest was distributed through the wound channel in pieces ranging from substantial fragments to particles small enough to elude any search that the period's diagnostic tools could conduct. Those tools did not include any form of imaging. The X-ray did not become a medical diagnostic resource until 1895, and its availability on the frontier lagged the technology by additional years. A physician treating a gunshot wound in the 1870s or 1880s had one instrument available to locate what was inside the wound: his hands, his fingers, specifically, and the metal probes that extended the reach of those fingers into spaces the fingers alone could not access. The physician who arrived at a gunshot case in the frontier period did not arrive in the sterile context that modern medicine has built around surgical intervention. He arrived in the context of his day, which had included other patients and other wounds, and the accumulated physical contact of profession practice without the bacteriological understanding that would eventually redefine what sterile meant and why it mattered. Germ theory was not accepted medical consensus in the American frontier period. The work that would eventually establish the relationship between microorganisms and infectious disease was being conducted in Europe during these same decades, and its adoption in American medical practice was uneven and slow. In the frontier context, it was largely absent. The physician who carried a blood-stiffened coat as a visible record of his clinical experience was not understood to be carrying a biological hazard from one patient to the next. The coat was understood as evidence, a credential worn on the body. A man who had treated enough wounds to stain his coat that thoroughly was a man who had seen enough to be worth consulting. He came to the gunshot patient, and he assessed the wound's location and the patient's condition with the diagnostic tools available to him, which were observation, palpation, and experience. Then he began the search for what the bullet had left behind. The probe entered the wound channel. This was not a metaphor for a gentle exploratory process. The probe was a metal instrument, typically a long, thin rod with a tip designed to navigate tissue without cutting it further, and it was introduced into a wound that was already a site of acute traumatic injury, nerve endings exposed, and responded to every input with the full physiological alarm that acute pain produces. There was no anesthetic in common use on the frontier. Chloroform and ether existed and were used in some surgical contexts, particularly for amputations, but their administration required equipment and expertise, and a controlled environment that the improvised settings of frontier medicine rarely provided. The patient was present for everything. The probe moved through the wound channel, and the patient's body communicated its objection through every available channel simultaneously. The muscles surrounding the wound contracted against the intrusion in a reflex that was not under voluntary control, and that complicated the physician's work by changing the geometry of the channel he was trying to navigate. The probe encountered tissue, and the patient felt it as something that the word pain addresses only approximately, a sensation that occupied the full bandwidth of conscious experience and left no capacity for anything else. When the probe contacted bone, the sound produced traveled to the patient's own skeleton directly to his auditory system. It was not heard in the way that external sounds are heard. It was felt as a vibration originating inside the body, transmitted through the structure of shattered bone and the metal instrument pressing against it, arriving at the ear by a route that external sounds do not travel. Witnesses who observed frontier surgical procedures and left written accounts returned to the sound with consistency that suggests it registered as categorically different from anything else the environment of the operating room produced. The fingers followed the probe, or preceded it, or worked alongside it, depending on the wound's geometry and the physician's assessment of what the situation required. The fingers were ungloved. Surgical gloves did not become standard practice in American medicine until the late 1890s, and their adoption, like everything else that bacteriological understanding was slowly changing about medical practice, reached the frontier last and least completely. The fingers that entered the wound carried the surface contamination of everything they had contacted that day and the days before it. The wound was not a sterile environment before the physician's intervention. The bullet's passage had already introduced into the depths of the wound channel whatever material it encountered on its path through the patient's clothing. The frontier garment, as this channel has established in previous episodes, was not a clean object. It was a repository of accumulated biological material pressed close to the body through weeks and months of continuous wear. The bullet that passed through a wool coat, a linen shirt, and a cotton undergarment before entering the body carried fragments of all 3 layers into the wound, along with everything those layers had absorbed during their time on the body. Bacteria did not require physicians' fingers to enter a frontier gunshot wound. They arrived with the bullet. The physician's fingers supplemented what was already there. The fragment search could continue for an extended period if the bullet had fragmented significantly and the pieces had distributed themselves through the wound channel in ways that defied easy location. The physician working by touch alone, in a wound whose internal architecture had been disrupted by the ballistic event, navigating by the faint tactile feedback of metal probe against lead fragment through layers of damaged and contracting tissue, was conducting an investigation without a map in a space that was actively changing around him as inflammation progressed. Some fragments were retrieved. Some were declared unreachable and left in place, on the theory that a buried fragment that the body eventually walled off in scar tissue was preferable to the additional damage of continued searching. This theory was not wrong in all cases. It was catastrophically wrong in enough cases to constitute a pattern, because the material that accompanied the fragment into the tissue was not inert, and was not going to become inert simply because the body had enclosed it. The infection that followed a frontier gunshot wound was not a complication in the statistical sense of an outcome that occurred in some percentage of cases. It was a default outcome, the biological consequence of introducing contaminated material into deep tissue without the antibacterial tools to address what had been introduced. The wound that appeared to be progressing reasonably in the days immediately following the injury was undergoing changes in its deeper layers that the surface presentation did not reflect. The inflammation building around the contaminated tissue. The bacterial population establishing itself in the damaged muscle that had been deprived of its normal vascular supply by the bullet's disruption of the local circulation. The immune response deploying against an infection that was already beyond the point where deployment could achieve resolution. The fever arrived. It arrived in the frontier gunshot patient with the same reliable schedule it arrived in the dental abscess patient and the cholera patient, because it was the same physiological response to the same underlying condition, the body recognizing systemic infection and raising its internal temperature in an attempt to create an environment hostile to the organisms producing it. The attempt was not always unsuccessful. Some patients' immune systems, in combination with whatever physician had applied to the wound and the patient's own baseline physiological reserves, managed to contain the infection to a level the body could eventually overcome. Others developed the particular progression that the frontier associated with the smell. Gangrene announces itself with the nose before it announces itself through any visual sign. The smell of tissue that has been colonized by the organisms responsible for gas gangrene is a specific and unmistakable sweetness that appears in this channel's accounts of frontier death with a regularity that confirms its role as the scent signature of the era's greatest medical failure. It is sweet in a way that something fundamentally biological is sweet, a fermentation smell, the smell of organic material being processed by organisms that are indifferent to the fact that the material they are processing is still technically part of a living person. The tissue changed color. The progression from the normal pink of healthy muscle through red and purple and green, and finally to the black of tissue from which all vascular function had been withdrawn, was a visual timeline of an infection advancing faster than the body could organize a defense against it. The boundary between living and dead tissue moved. It moved toward the center of the body if the wound was on a limb, progressing along the tissue planes that connected the extremity to the trunk, following the path of least resistance through the structures that the infection had not yet colonized. The saw was the answer the frontier's medicine offered to this progression, and it was an answer with a narrow effective window, on either side of which it was either unnecessary or too late. Amputation performed before the infection had crossed the joint removed the infected tissue along with the limb and gave the patient's immune system a fighting chance against whatever bacterial load remained in the surgical site. Amputation performed after the infection had moved past the joint removed the limb and left the infection continuing its advance in the tissue it had already reached, and the patient faced the same outcome with less body remaining. The decision about when a cut was made by a physician working without imaging, without laboratory culture, without the diagnostic tools that would eventually make the boundaries of an infection visible and quantifiable. He was working by observation and experience and the tactile assessment of his hands against the patient's skin, trying to determine where the living tissue ended and the irretrievably compromised tissue began. He was sometimes right, He was sometimes wrong in both directions. The consequences of being wrong in either direction were the same. The men who died of gunshot wounds on the frontier mostly did not die of the bullet. They died of what the bullet introduced and what the treatment added to it. They died of the clothing fragment that spent 10 days in the wound before the infection. Its seed became visible at the surface. They died of the physician's fingers, which carried into the wound the accumulated biological residue of a practice conducted without bacteriological awareness. They died of the contaminated probe scraping the shattered bone and depositing on the fragment of lead it was trying to locate the same invisible cargo that everything else in the procedure was depositing in the wound's deeper layers. The revolver hanging on the cowboy's hip in the Hollywood film is an icon. It communicates something about the man wearing it, about the period, about the particular version of freedom and danger that the frontier mythology has constructed around the gun as object in the operational reality of the frontier. The revolver was a delivery mechanism for a sequence of biological events that the period's medicine was not equipped to manage, and that the patient was not equipped to survive at any reliable rate. The bullet was the first event. It was rarely the final one. What would do it for you? The bullet's arrival, the physics of soft lead encountering bone, the sound that travels through your own skeleton to your own ears, or the 10 minutes after, when the physician's hands enter the wound and the search for what the bullet left behind begins, and the anesthetic being offered is a glass of something this channel has already told you about in considerable detail. Both are waiting for you in the same room. You do not get to choose which comes first. Leave your answer in the comments. And if you believe that the gunshot was the worst thing frontier medicine was asked to manage, consider what the same physicians and the same tools were doing in the mouths of the people those guns were pointed at. The blacksmith's chair, the rusted pliers, the sound of something that should not break breaking. All of it is waiting for you in our video about the real dentistry of the Old West. Click on the screen. Raw, visceral, history. This is the raw frontier.